Um, in the interest of a reasonable finish for everybody to get their tea, I'll make a start. My name's Ian Bowns. I'm a retired public health doctor, and I shall be talking for as few minutes as I can manage, in order that we get some opportunity for people to discuss what I'm saying, because I think some of what I'm saying is certainly opinion. Some elements are opinion, and there may be some differences about that with some of my colleagues. And some of it is there is considerable amount of uncertainty in the background research, and the whole of this, I suppose, talk is really about how we're going to manage uncertainty and risk. And it's something that humans seem to be particularly bad at. They overestimate low risks, and they don't always have a good perception of the relative risk of different activities. And that goes for me just as anybody else, I'm sure. So I'm just going to share my screen so that I can start running through a few slides. And I will share screen because I might at some point be asked a question that requires me to show you some data, for example. I'm going to talk really about practical precautions that we can and can't take in the current circumstances, and going forward over the next few months particularly. I need to pay a particular thanks to Steve Pagden, who can't be here today, but who has actually done quite a bit of the work on some of these slides, and we will make the slides available through the website, I hope, partly because there are some quite useful links that Steve's found, and a few that I've added that take you to things like the guidance from on the government websites, but also things from the Centers for Disease Control in Atlanta in the States, who usually produce thorough and accessible guidance on communicable disease. Now, I'm going to start with how did we get to where we are with, in effect, stuck in the third stage of the 4 stages of easing the restrictions. And fundamentally, it was because cases were increasing. Now, I'm hoping people can see that. Let me just hide you so that I can see. Now, essentially, the delay is down to this increase in cases. I hope you can see my mouse so that I can actually point to some of these things in the graphs. Now, in particular, you'll note that this is just an example of Bolton. Bolton are not the only place, but they were probably one of the first to start to show increases, and have been followed by a number of other local authorities, particularly in the Northwest, but now no longer really confined to the Northwest. There are authorities in a number of places around the country. And certainly my reading of the pattern in the Northwest is that it may well have started in one place, but it seems to have spread over the borders into neighbouring areas. And some of you here, I know, will be living in one of the neighbouring areas and may well have experienced some of that increase. But the thing is, you'll notice it's predominantly in younger people, although not exclusively. And infections have been predominantly among those who are unvaccinated, largely because they're probably people who have not had not at the time they became infected been invited to be vaccinated. It's not necessarily because they have chosen not to or turned down a vaccination offer. It's simply that there are we're only just finally getting to the very youngest stages in every part of the country. Now, thankfully, there hasn't been the same corresponding increase in hospitalizations and people requiring intensive care, and no discernible increase really in COVID deaths. Although just worth remembering that at the time the cases started going up, people would have had people taking the decision to delay releasing the restrictions would have been thinking there's a delay between cases going up, people becoming sick, and people becoming sick enough to be in intensive care or die, and so waiting for any other more serious signs of a problem would probably have put even greater risk of an increase in cases. Now, if we move on to look at Sheffield, you can just see that we have some increase, in particularly in the younger age groups recently in Sheffield, but interestingly, not to the same extent as in many authorities in the Northwest, and a number of the other cities, notably Leeds and Bradford, significantly higher, and one or two other places in Yorkshire are also higher. So that's the reason, essentially, why we are where we are. Now, this has also been contributed to by the fact that the Delta variant has become the dominant variant. But, and I'm not going to go through the whole of this slide, mainly because you can read it more quickly than I can. But the key point is that vaccinations are protecting people. So the risk in those who've received 2 doses is many times less than the risk among those unvaccinated. Now, it's worth pointing out that there will be cases among people who are fully vaccinated, because the research showed that the vaccines are not 100% effective. We knew that. They're just, what I would say is that they are more effective than we might initially have hoped a year to 15 months ago, when people were first starting to develop them. They'd have been, made a huge contribution, even if they hadn't been as effective as they appear to be. Certainly, they seem to be very effective in the research and in experience since the rollout of the vaccine at preventing serious illness. Now, the other point that it's worth making about this particular variant is that the symptoms that have been spotted, and this is again data from the Zoe app, that the symptoms that are being reported there is that the symptoms are becoming less specific. So the symptom that was particularly peculiar in a sense to coronavirus was the loss of taste and smell that a lot of people noticed that isn't present with a lot of other respiratory viruses, and that is much less dominant with the Delta variant. So many more people are reporting things that might well be indistinguishable from any other viral respiratory infection. So you can't rely on a very particular symptom to say you've got or not got COVID. In a sense, this, in my mind, makes it more important to get a test if you do develop symptoms that you think might remotely be COVID. Right. It's not the first variant. There are several variants, and there are a number of places you can go to look where people are tracking all these variants as they change in different countries, and it's unlikely to be the last. But so far, we've been fortunate that the vaccines seem to retain most, if not all, of their effectiveness against most of the against all of the variants we've seen today. Right. Now, the current rules and guidance are that we're remaining in step 3 with a few minor changes. Anything that's blue and underlined is a link. So if you want to follow through and look up what all of the current guidance is, and the page that's linked here on the government website is actually quite good at you being able to find particular topics and particular circumstances and situations where there might be particular restrictions. It also includes a list of areas with high case numbers and the Delta variant and additional precautions related to those areas. For example, just basic advice about minimizing travel to or from those areas so that people aren't spreading it. This doesn't include Sheffield at the moment. Now, the basic rules are still supposedly groups of 6 people, 2 households indoors and outdoors up to 30 for I'll pick up the questions when I get to the end. I've just noticed one in the chat, so I'll pick those up at the end. Up to 30 people for social events, but as we've seen recently and are aware, sporting and some of the performing arts, particularly those who are involved within the event research program, have been dealing with much greater numbers of people, and there's guidance on the website of the Department of Culture, Media and Sport about both professional and amateur performing arts. Just to stress that what actually didn't happen yesterday was that we didn't actually have all these restrictions, legal restrictions, removed. Nothing in effect went dramatically backwards. We didn't revert to step 2 or anything. It's just that we've delayed moving out of step 3. For some reason, my mouse is not moving things on. Right. So the current position, from my point of view, and looking forward in the near future, it's the longest I dare to look forward. Vaccination has afforded good protection for most of those at the greatest risk. There's still a very small proportion of older people who haven't taken up the vaccine. I think it's about 5% of those over 65 in Sheffield haven't even had a single dose. But that's pretty good uptake. Those of us who've been involved in vaccination programs, that's almost unprecedented in terms of vaccination uptake for any kind of at-risk group. Cases are increasing and are likely to rise and fall over coming months, but they are mainly among the unvaccinated. And depending partly on variants, and will depend in the future on variants, and that's why the variants are being tracked so carefully, particularly in the UK, but in a number of other countries as well. Serious illness seems to be much less frequent, although we're hearing reports from hospitals, including in Sheffield, that there is an increase in admissions, but they are predominantly among younger unvaccinated people, although there are still a few of those who are at risk who are becoming ill. Even with full vaccination, there will still be some cases like that, and there still are some cases like that. But that's all other things being equal. If we get a variant which is more transmissible. We may well get more cases, and if we get more cases, we'll get more people who are ill. That's pretty much inevitable. But we might also get a variant which caused more serious disease, and that's why we need to try and press on with vaccination, not just within the UK, but more widely. Now, coming on to what we should or could do to protect ourselves. Now, what I would stress is, and repeat, this is about risk management. Nothing is risk-free. I'm always interested to see the press reports when the death mortality statistics come out each year or every few years of deaths from accidents, because they always seem to focus on the things that people have had an accident with that seem completely innocuous. And they seem particularly fond of reporting on the fact that a handful of people die each year in accidents that are related to putting on or taking off their socks, or putting on pullovers while they're walking up and down stairs. So nothing is risk-free. And this is all about managing the risk in a realistic way and a proportionate way to the risk that we're going to face. Now, what should we do to manage the risk? Again, I'm not going to read all of these points because you can get there quicker than I can. But one point that I added to this, because Steve had done this basic risk, is that in deciding how to behave, one thing that many lists don't actually mention is the point about the amount of virus that is around in your community is a big contributor to the risk. If you're currently walking around Auckland in New Zealand, you could probably do most things, and you're probably allowed to do most things, and your risk will be very low. And a large part of why your risk is low is because there's very little virus, if any, around in Auckland. Now, as cases change in particular places, you may wish to adapt your behaviour to mitigate any risk from having more virus around. So while cases are going up, maybe there is a case for people being a little bit more cautious about how much time they spend in crowded places, and they may choose to wear masks in places that when there's less virus around, they might not wear a mask. And the other thing that I would like to keep stressing is this point about, particularly now we've got a variant with very unspecific symptoms. If you're feeling unwell, isolate, keep yourself out of the way of other people. Don't put somebody else at risk. And actually, I think in future, that's a lesson that we could usefully learn for other respiratory infections, because I think there are, historically, people have tended very often to soldier on with a respiratory infection, turning up at work, etc., going to social events. I can think of instances when I've been guilty of that. And maybe we should transfer this change of behaviour that's arisen as a result of COVID to the flu season anyway, just to some extent. If you're feeling ill, don't put somebody else at risk. Right. Now, the not thought to be the main way the virus spreads is a direct quote from Centers for Disease Control in the States. Now, I think that we may have overemphasized the issues about contact with contaminated surfaces and hand washing, but it is still a potential source of transmission. And the one great thing about hand washing is that it will cut down a kind of final pathway to you for the virus, because if you go around handling lots of objects, but if you keep your hands clean, you're much less likely to catch the virus yourself or transmit it to someone else or another object. and there's guidance here linked on how to reduce the spread within a household, because that can be a particularly difficult issue, particularly for people who don't have masses of spacing and live in relatively modest, crowded housing. Now, masks. There's a really good source, as Steve's identified here, for the CDC guidance for wearing masks. It's not just a matter of wear the same disposable one for weeks on end. There are issues about putting them on, taking them off, and disposal of disposable ones, or keeping reusable ones clean. The key thing is that you're there, it's thought to be there to protect others from you as a potential source, although there's quite a bit of evidence that in a number of circumstances it does protect the wearer to a degree as well. But it's not a substitute. It can be traded off to a limited degree, I think, as all risk mitigation measures can. Space is the big thing. If we're looking at something which we now believe to predominantly spread by air, the key thing is that it's actually quite difficult to have the same circulation of air indoors compared with outdoors. You just got to take an awful lot of steps in an indoor space to have anywhere near the same circulation of even a still day outside. And there's quite a lot of guidance to that effect. There's Steve's linked here to an HS Health and Safety Executive notes on ventilation, but the takeaway point is at the bottom, that the airflow in and out of an adequately ventilated room are much lower than you might be expected outside. So whenever you can, if at all possible, try to meet people outdoors, take advantage of the sunlight, get your vitamin D as well, and reduce your and their risk. I was asked a very specific question at one point about what's is it safe to hug? Well, is anything that involves social contact safe? Everything will carry some risk, but you can manage these risks. And the whole issue is that we're in a position to assess these risks and do a little bit more to manage them. So obviously, if you're in close physical contact with more people more often, if you're in contact with people for longer, if the embrace is face to face, these are all thought to increase the risk. But so therefore, try and manage the risk depending on the situation. I would say how much you value the personal relationship, your own tolerance of risk, and the other person's tolerance of risk. And bear in mind that there are people you might then put at risk later. So for example, a carer for somebody who's vulnerable and maybe couldn't be vaccinated or is seriously immunocompromised might choose to react a little bit more risk aversely than somebody who is themselves fit and well and is unlikely to be coming into contact with anybody else. What I would say is, if you are going to do this, just do it and don't feel guilty about it. So, from the conclusion about that, I would and have hugged family and close friends, and particularly if people are having a difficult time. But I'll stay to Zoom for this meeting if it's all right with the rest of you. So, now, we've put a title of around the new normal, and these really only almost personal observations to some extent. One thing I do hope that will come out of the COVID episode is that we'll be a little bit less complacent about the potential risks of infectious diseases. Some of the countries in the Far East that experienced SARS-1, which is the earlier relative of SARS to COVID, were much more, I think, alert to the particular risks of this type of virus and acted much more quickly. I think the West in general was complacent to a degree. In the UK specifically, UK and US, I would say particularly. But I do remain a bit concerned that the UK will fail to learn the lessons from this. And particularly was a bit apprehensive when measures were taken to reorganize the public health services that combat these sort of outbreaks before we'd had chance to do a full review at the end of this episode. It seemed premature. I think we also need to find the right place for the COVID risk in comparison with all sorts of other risks. I mean, a large part of the risk of COVID was the risk of that people were in poverty. It's undoubtedly affected poorer people in terms of higher infection rates, and because they very often have other long-term conditions, or more often than the general population, it's had more serious effect on them if they become infected. But we do need to try and get a sense of proportion. Seasonal flu does cause excess seasonal deaths in many years. And we need to get the right kind of sense of proportion about the risk and how that relates to COVID. Now, what I don't think we'll be able to predict terribly well is that when the regulation and the guidance are all removed and essentially government says, there are now no legal restrictions, you can travel where you like, you can do all manner of things that we haven't been able to do for 18 months or so, I think habits may well have changed. And those of you like me who've been able on occasion to visit places in the Far East, China and Japan, will have seen and maybe felt a little bit superior to people who were going around years ago wearing masks and thought they were overreacting. Well, I think our attitudes may well change as a result of this to that, but some of that will be an individual decision. But I suspect that some service providers may expect just slightly different things of their service users at various times. Now, just one word on revaccination, top-up vaccinations. Regular COVID vaccination may well need to be added to the current programme for older people. But bear in mind, that's not that unusual. Following a very bad winter towards the end of the last century, was when we ended up with a seasonal flu vaccination program in the wake of a very serious flu season. We also have vaccination offered for shingles and pneumococcal disease, which can be particularly serious in anybody who's vulnerable. And obviously, we're recommended a range of vaccines when we travel to, and to some particular places, there are actually still legal requirements to have, for example, yellow fever vaccination. I've got my little yellow fever book because I can't remember which country it was, but I was actually required to have it before I was even allowed over the threshold. Now, that's me finished. I will try and answer any questions anybody may have. But what I would like to move on after that is to have some group discussion on what that might mean for you, and also get some feedback on what sort of questions have I completely failed to answer for you. The figures in different areas. As far as I can tell, looking at it, the biggest factor in the infections is the demographics. And I think it's going to be the younger unvaccinated age groups to a great extent. But there may well be some issues of trust in the advice. But I suspect a large part of it is that is the amount of travel to and from somewhere like India, where the Delta variants already had a dramatic effect, and bringing it back. It's rather like when the when COVID very first entered the UK, there were actually a number of very particular places that actually did have discernible outbreaks brought into the country from abroad. So I think there was an outbreak in Cumbria and down on the south coast, and I think that, you know, the countries that were alert to this in the Far East would have been on top of those really forcefully to try and control and contain them. And I think we failed last year to do that. And there is evidence that it's the reliance on solely on vaccination as the response to that, and not a stronger response in terms of case identification, backward and forward contact tracing, isolation, making isolation the easy thing to do rather than making it actually hard and unaffordable for a lot of people. I don't know whether that's at all answered your question, Tom, because to some extent it's hard to tell. The vaccination rates don't always differ very much, for example. So I've got Jack and then Paul.
Thanks, Ian. Really good stuff. Just to tell you that I spoke to somebody today who is having some symptoms, not feeling well, has a headache, and is a bit chesty. And I said, and who's having regular lateral flow tests that are all negative. And I said, you know, perhaps you should get a PCR. And he tried to get one online. They wouldn't give him one online. And then he rang 119 and they said, you don't fit the traditional symptoms of fever, cough, and loss of smell and taste. Anyway, and wouldn't give him one.
That's very disappointing.
So in terms of what you've said about the Delta variant and things like headache and the fact that symptoms have changed is, as you say, very disappointing. But it's just to warn people that
it is,
you know, it's the government, the guidance hasn't kept up with recent changes. Yeah. Just to let people know.
But just to go back to what I touched on earlier, Jack, I would also say it sounds like it's a respiratory virus that can be passed on to other people. And if it's made this person ill, it might make somebody else ill. So just almost act as if you've got COVID, but just because it's a not particularly pleasant illness, that it'd be nice just for it to die out with that person who caught it, or that chain of transmission to come to an end because it hasn't been passed on to 5 other people at work or something. So, you know, if you really think you're ill enough, even if they won't give you a test, just act as if you had. Paul, what?
I was just going to come back to Tom's question, because as well, some people know that I live in Calderdale, not far from Halifax, and we're a bit like Bolton. And what we found, and it's been ever so interesting, doing the street work, which people from the upper Calder Valley contact tracers have been doing. And this has been going on for a long time now, because we had a surge in cases last sort of July, August, and spent most of last year locked down, as did Bolton and these other places. And what we found is that, firstly, looking at the local data, the age structure of the population is important and that's relevant. But the difficult situations were in communities where a high number of the population are in jobs where they face the public.
Yeah.
And we just found time and time again that it was the care workers in the social care homes, the hospital workers, the taxi drivers, the shop workers, and then added to that, if people were living in multi-generational households, and you're in a pickle. And I strongly suspect that that's just the same in Bolton, that it's a low-wage economy, lots of people are struggling, and I'm just really concerned that the new normal will be COVID continuing to circulate in these communities. But I think it's a difficult situation. But I don't know. I mean, you asked Tom whether, do you behave better in Sheffield, or is it to do with demographics? And the director of public health in Calderdale absolutely slammed that one ever so hard, because it just wasn't the experience on the street that it was young people behaving badly. It was young people going to work, and doing jobs that we don't want to do. That's all.
I think I was also, though, trying to draw the distinction between why we've got high levels in certain places and then not so high levels in places that are essentially very similar. And I think there is an element of fortune to that, to do with whether or not somebody happens to have come back from an area where the Delta variant was dominant, and brought it into a community, and where it then spread among the sort of groups who've got little alternative but to be in contact with each other. Because when you look, there are similar places that haven't done quite so badly. Why is Sheffield so much lower than Leeds and Bradford, for example? I don't think it's down to vaccination coverage necessarily. But anyway, I can't see any other questions.
I put it on the chat. I'll put it on the chat now.
Sorry. Oh, right.
It's just anecdotal evidence of a friend of ours who has had lots and lots and lots of lateral flow tests and does them very regularly, etc., all negative, and then one PCR comes back positive, and just wondered if there's any evidence that the new variant isn't being picked up by the old old style lateral flow tests, really.
Well, that I don't know. I don't know whether anybody else here's got any insight into that. I've not seen anything myself. What I would reiterate is that we get, I think we would kind of expect lateral flow to miss maybe half of the old variants. They're helpful, but they're not as helpful as a sensitive PCR test in diagnosis, I wouldn't have said. But
Ian, what I understood is that the lateral flow, if it is positive, almost certainly does mean you are positive.
Yeah.
But it does miss an awful lot of positive cases. I've heard it only picks up 60%, but It varies about how well it's been, you know, there's all kinds of variables in terms of how well it's taken.
Yeah.
The PCR is much more sensitive and specific, although again, it's not 100%.
No, nothing is. I think hopefully one other thing that people will have learned as a result of this is tests aren't perfect. But anyway, I'm not sure. I can't see any other questions.
Am I allowed to make a little bit of a comment in relation to your the new normal, and with what Paul just said about sort of redefining what frontline means, and our hope that frontline workers will be more respected and more appreciated and more protected and those sorts of things. And I think this is just one of the other things that the government is not doing. So with the, you know, pay offers to the nurses, etc., and you know, the not supporting people when they do try to self-isolate, all those things point to exactly the opposite, really. The government's used it as a way of screwing down on certain features of welfare benefits, etc., rather than redefining the importance of these frontline workers to the rest of society, really. So I think the hope that the government would learn about, for example, international travel, supporting people to isolate, you know, the whole role of frontline just has been completely, you know, run into the sand, really, in my humble opinion.
Yeah, I would agree. But the only thing I would say is that what was interesting was when ONS looked at the occupational risk of kind of death and serious outcomes from COVID. You know, the slight surprise, in a sense, for many people was that care workers and healthcare workers were at increased risk, but there were groups at higher risk. You know, people in public transport, for example, and some aspects of branches of retail, I understand, were at even higher risk. So yeah, it's important to kind of get a sense of perspective on that. Okay, well, I've probably taken up. We've now got, it's now approaching 10 to 5, and I was going to suggest that perhaps we divide up into, have we got 3 groups, Alex, do you think, or?
I've done 4.
You've done 4.
I can change it to 3.
No. Smaller groups, more participation. But I was going to just reiterate the questions I had in my mind were around what does this mean, and what else might it be useful to know, if we can, to try and help us manage our way through the next few months, particularly. And maybe if each group comes up with a handful of each, and then when we come back in maybe 25 minutes, come back at 15:15, and if we just go around the groups and have one at a time of each, just to try and get a little bit of feedback on what people might need in future. Hi, can everybody hear me?
Yes.
Good. Have we got everybody back? I can't quite see. I'm assuming we have. Let me see all of us. Right, must have lost a few on the way. I'm going to take you know, chair's prerogative slightly, because I was in a group with Fran, Nick, and Vicky, and just get the ball rolling with one of the points that was made in our discussion. We tended to focus rather a lot on things that we don't know, or we maybe could additionally find out. But one point Nick made that I'd omitted, which I think is really important, is that in assessing risk going forward, we've got to make sure that the cure is not worse than the disease. So maintaining too rigid restrictions for too long risks doing more harm from those measures than any benefit we gain from controlling COVID. So we know that people have not been able to obtain other hospital care because hospitals were busy last year with COVID, and we need to get those services moving again. We know there's direct harm from people being off work, missing social contact, the mental and physical health consequences of all that. So that's us kicking off with one point. Who else was going to report back from the other groups? Mayor? You're still muted. You should be able to unmute yourself.
Yeah, there we are. Hi,
Fire away.
Jack, Louise, Farah, and myself. Was that everybody? Yeah, I think so. Louise, who's been working at Page Hall Hub, raised, the issue of the Roma community being probably one of the least vaccinated groups, and what else to do and how to do it. And Jack reminded us that the City Council have sort of put some outreach to us that they want us to help with things. We talked about how it's a really long term, almost a generation to change sort of attitudes, and that it may be more benefit from finding out what the Roma themselves feel would improve their overall health. Not focus just on COVID, but focus more on inequality and diet and exercise and other things, because it's sort of, you've got to try and push against an open door rather than push against a locked door of persuading anyone else to have vaccine.
Yeah.
And that was the main thing. Anything else, Jack?
Not sure.
There was a question about what proportion of people in, say, a small community, poor, say, Roma community, need to be vaccinated to protect them. We weren't sure. That was a question, because we know that in those communities the levels are lower. So is it 75%, 80%? Well, has that changed with the variant? That was one question. And the worry is that this will become an endemic disease of poor areas, and just the inequalities will just remain.
Yeah. So I suppose what that point about in effect what's herd immunity in a part of the community is something that's concerned me, because there are some quite big differences in young uptake from younger age groups. I've been looking at the latest figures in the west and of the city. We're talking about 80% of younger groups have been vaccinated, whereas in the middle and the east of the city it's 40%. So we've got some quite big differences, and those are also, as I say, the areas where we've got the lowest coverage of vaccination in the older age groups. So if we've got a lot of younger people unvaccinated who can't isolate themselves, who can't necessarily readily change their behavior to reduce their own risk, are also in the same place where there are vulnerable people, including in the same household, they're going to be remain at risk. Have we got another group to report? Or did we end up in two groups in the end, Alex?
I think it was 3 groups, but they were quite small.
There were, but have we got anybody from the third group, or have they all decided to go?
We discussed, it was Paul and Paul and Tom. Paul and Tom, and we discussed many things, but one of the things, to what extent people would change their behaviour because of COVID. So Tom explained that, because he had it so strongly, he would change his behaviour, and for example, international travel. But we discussed that maybe sections of society, above all young people, that had either been not so strongly affected or hadn't seen anything traumatic in their families or surrounding, would not necessarily change their behaviour. So we might get quite differences in changes in behaviour in different sections of the population. And Paul raised very clear the question of the messaging, that the message is still not clear. There's still there's still not a clear message from the government or from councils about what needs to be done. That was partly what we discussed, amongst many other things.
Okay, just to try to complete the picture from our group, there were really a couple of other things we discussed. One was around uncertainty and knowledge about how long the vaccination will remain effective for those who've had it. And there is, as I understand it, there were some trials that have shown good durability of that protection, but only to the extent that they've been able to be conducted. We're only as far ahead as we can be with that, given the time that's elapsed since vaccination was introduced. Even in the clinical trial, we're only talking at maybe people who've got a year's experience of how long it might last. The other point that was made was about it would be good to have a test that was as accurate as possible, but as easy to use as a lateral flow test. So that had some of the features of the best features of a lateral flow test, the best features of a PCR, and was easy and cheap. And I've just noticed we've got something in the chat. The slides for us will be on the website as soon as Alex can get them up there. You know where the website is, so it's quite a small slide set. It should be easy enough to download for people, and I hope you find the links useful as well. Has anybody got any other points to make? Questions? Fire away.
And the only other thing I raised in terms of personal decision making, because the partner in my household is immunosuppressed, how much greater a risk? I mean, we're both fully vaccinated, so it's very reassuring, the figure of 1 in 16,100. So I'm making a decision to carry on with the gym class I'm doing unless numbers in Sheffield shoot up. But in terms of my partner who's immunosuppressed, how much more cautious ought he be if he's not got a proper immune response to the double vaccine?
There are
no one can answer.
There isn't an easy answer, because there is some research on very small groups of very immunocompromised patients that shows they haven't got much of a response at all. Whereas I suspect that there's a wide spectrum in terms of that effectiveness. And without being able to access some tests and some expert advice that relates to their particular circumstances, and even then it might be difficult. But Jack's got a finger up and might have.
I've just had a message today from Biobank. So people know what Biobank is. It's this huge study, and Biobank are asking me whether I'm willing to give them 10 drops of blood to tell whether the antibodies that I have are related to the vaccine I've had or to having COVID itself. So they're obviously being able to tell from that, something about whether have you had COVID or are you immune because of the vaccination. So there must be developing ways of measuring your immune response. Which I don't know where we would access that from, but presumably immunosuppressed, compromised people, may want to know those things.
That seems more useful, doesn't it, than all this money going on totally inadequate inaccurate lateral flow tests. So it would seem some more targeted money going on adding, checking your immune response. You know, my partner's having 3 monthly blood tests to check all his other hematology. So why not add his immune response, and then he'd know whether he needs a booster vaccination or not. That must be quite cheap, I would have thought, instead of millions of.
Personally, I would have thought that the thing that it would be really useful would be to try and get some advice that relate, you know, clinical advice from somebody who knows the circumstances and has some expertise within the immunology that's involved. They'll know whether a test will add information at that point.
The thing about Nick, sorry, Nick.
Nick had a finger.
I've got a couple of things that people have asked. I think I know some of the answers to a bit. The herd immunity question has been, because I looked at this today. What the current estimates of herd immunity percentage are likely to have to be. And the most recent estimates and projections are over 85% or around 85%. Now, the interesting question that was raised is about how that affects individual groups. If the group is very, very small, if the group is very geographically contained, then that figure will apply to the group. However, if you've got a mixed group that is genuinely mixed both geographically and in some other characteristic like age, the fact that you had over 85% in the 60-plus-year-olds, whatever, but much lower in the young people. Well, the 60-plus-year-olds and the young people will mix together, and that just drops it. But if the group is very geographically contained, and maybe some of the communities that you have just been talking about are, then that might be okay.
Yeah.
But that's the sort of figure, because the ONS survey of immunity is talking as if we're getting to around that figure at the moment, but who knows? The biobank, biobank have been a bit of a pain actually, because they've been doing these tests and people have been reporting about that, but it's exceedingly hard for people that are doing vaccinations to get told what they're actually doing, because basically there's two antibodies that they can look at. They can look at spike protein and they can look at capsid, which is the coating of the virus. What they tended to want to do, so far as we can tell, that it's been very hard to get the information out of them, is that they'd be more inclined to look at capsid, because that gives you a measure of the disease prevalence and not of the vaccination prevalence. So obviously, you don't want the one to be confounded with the other. But it's good to hear that you can do both. You can do both or either. And you've been able to do both or either for quite a long while, as far as I know. But it would be good if Biobank actually told people that are doing vaccinations what they're doing, because people come in and say, I've just been tested on the Biobank and I've got no antibodies, but my vaccine hasn't worked. And so it would be good if they had a bit more information.
Yeah. Tom?
I think that it sounds like the study that Jack has been invited to is a progression from the one that's going on at the moment, which is you test it yourself in the equivalent of a lateral flow test and test your blood, but you don't send it off for more detailed analysis. Yeah. So it's pretty crude, really. I'm part of Biobank and did that same test, but usually the other Biobank things they ask you to do and the other research thing, they don't tell you as an individual the answer. So it's just collected centrally. So all the, it's part of, part of their data bank really is that they hold all this information until until they use it for research, but they don't use it clinically or to tell you as an individual, having given your sample or having had those tests, what your results are.
Well, I've certainly vaccinated loads of people who've said that their biobank tests so that they haven't got
Yeah,
antibodies.
that's
after
the
the
little
first
thing
dose.
that they send around, a little
Right. Okay.
for their own individual PCR,
Oh, I see, okay.
VCR. What is it? Sorry, lateral flow.
Yeah.
Yeah, I don't know. But
It's,
it would. I mean, they should supply adequate information to people to actually participate.
But the other thing, just picking up on all the antibodies and stuff, I don't think there is a test that tests how immune you are.
No,
because
not as such.
the tests that are done, I mean, I'm not a great expert on this, but so as far as I know, the main easy test to do is what antibodies you've got. Circulating antibodies. It doesn't test whether your B cells are capable of being switched on very quickly to produce antibodies if they're needed. It just tells you what you've got swimming around in the blood at the moment. So a test that's easy and quick to tell you how immune you are, I'm not sure exists.
No.
It obviously, if you have got loads of antibodies swimming around, then you probably are quite well. You probably are quite well protected. But I suspect, especially looking at the cell-mediated immunity importance in the vaccination program, that there are loads of people with low levels of antibodies that have been vaccinated and they're still low levels, but actually they're capable of switching on antibody production and T cell production very quickly, which is why they're getting protected. So if you've got loads of antibodies, that's good, you're probably protected. But if you haven't, it doesn't mean to say you're not.
No, the only thing I would add is that the discussions that Jack's had with colleagues in hospital have said that they are seeing vaccinated immunocompromised patients, but the immunocompromised, immunosuppressed is a very broad church.
Yeah, of course.
In the sense that there are people who are on immunosuppressant drugs in relatively low doses for particular conditions, and there are other people who have, for example, as we have a relative, he's had a second bone marrow transplant during all this. That's a different category of immunosuppression altogether. Which is why I say it's very hard to make a judgment about an individual, because the different clinical circumstances need to be looked at. So it's hard to be helpful. I'm sorry. I think, have we reached a natural conclusion, folks?
I think so.
Well, thank you very much for.
Thank you, Ian.
And I hope it's been useful, and we've kind of been able to
Very useful, Ian,
and get a little bit, become a little bit more
Thank you.
comfortable with managing this risk as we come out of these difficult times. So,
Yeah. Thank you. Thanks a lot, Ian. Great.
and stay well.